From the JAMA Network, this is JAMA Oncology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Oncology.
Hello and welcome to our listeners around the world. You are listening to JAMA Oncology Author Interviews. Thanks for joining us. I am Dr. Vivek Subbiah, medical oncologist and Chief of Early Phase Drug Development at the Sarah Cannon Research Institute, Nashville, Tennessee. I'm the JAMA Oncology podcast host for today and also the web editor for JAMA Oncology. Today, we are going to be discussing a paper that has been published in JAMA Oncology. The paper is titled New Definition of Light Chain Monoclonal Gammopathy of Undetermined Significance, Revised Serum Free Light Chain Reference Levels. Here, the authors propose a new definition of light chain monoclonal gammopathy of undetermined significance. Hereafter, we are going to be calling this MGUS. Today, we have Drs. Thorir, Einarsson from Skåne University Hospital, Lund, Sweden, and Dr. Ola Landgren from the Division of Myeloma, Department of Medicine, University of Miami, Sylvester Comprehensive Cancer Center, Miami, Florida, USA. Dr. Long, please, can you go ahead and introduce yourself?
Yes, hello. Many thanks for the kind invitation. I'm very happy to be here. My name is Thorir Einarsson, and I'm a postdoctoral researcher at the ISTOP-MM study. And I'm also an internist and a soon-to-be nephrologist here in Skåne University Hospital in Lund, Sweden.
Thank you so much. Dr. Landgren, can you please introduce yourself?
Hi, I'm Ola Landgren. I am professor of medicine. I'm chief of the Division of Myeloma and director of the Myeloma Institute at the Sylvester Comprehensive Cancer Center at the University of Miami. I have worked very closely together with Dr. Christiansson and Dr. Long and the team. Dr. Christiansson is the lead PI for the study, and I, together with Dr. Christiansson and Dr. Harding, have been the co-PIs putting together the entire study that's been going for a long time, the ISTOP-MM in Iceland.
Thank you so much. Thorir, could you walk us through the main findings of your study and explain the significance of the new definition of light chain monoclonal gammopathy of undetermined significance, also known as LC-MGUS, for our broad listeners?
Yeah, so the ISTOP-MM study is a nationwide screening study for monoclonal gammopathies, MGUS. It's been going on for a long time in Iceland. It's, to our knowledge, the largest screening study of monoclonal gammopathies to date, where we have screened over 75,000 individuals over the age of 40. That is more than half of the Icelandic population over 40 years old. And we have screened them with both serum protein electrophoresis, immunofixation, and serum-free light chains. Those that have had MGUS, those individuals that diagnosed with MGUS have been randomized for different follow-up arms to try to assess how to follow up and if screening is beneficial or even harmful. In this study, we have looked at the free light chain measurements in all these individuals. And a few years ago, we published a study where we looked at those with impaired kidney function, that is eGFR below 60, and we redefined the reference intervals based on eGFR for these individuals. And now, in recent years, many small studies have indicated that the original reference intervals have been inaccurate in individuals also that have preserved kidney function, that is eGFR above 60. So in this paper, we have looked at over 40,000 individuals that have preserved kidney function and or without monoclonal gammopathies, and we redefined the reference interval for free light chains. And by that, we have also redefined the definition of light chain MGUS. By revising this new definition of light chain MGUS, we have decreased the false positive rates of light chain MGUS by 82%. And when we have followed up these individuals that we are now undiagnosing with light chain MGUS, none of them have progressed to a lymphoproliferative disorder over that time. So that's the main results.
Wow, thank you so much. 82%. Wow, let me ask the next question to Ola. So with the revised serum free light chain reference intervals, your study mentions an 82% decrease in the prevalence of LC-MGUS. So Ola, what impact do you foresee this having on clinical practice and patient care?
I think that's a very great question. What impact will this have? I would like to take a step back before I answer the question. I want to say that this is an illustration of how reference numbers are generated, and then we learn more over time, and sometimes we change our mind what the normal reference is. The reference scale that has been used up till now for the light chains was based on 282 healthy blood donors. And that's how we arrived at the current definition for what a healthy person's reference should be. But when we screened the Icelandic population about the age of 40, we had over 80,000 people, as you just heard. The numbers came out differently. And this mimicked exactly what we have seen for us who have been in practice for a long time, doing this blood test on people. The 282 individuals that formed the reference range, they were very, very healthy young people. But in practice, we have people of different age groups and people have underlying conditions. So we always felt that we had diagnosed too many people with abnormal proteins, and we were not really sure how to manage these patients. I think with this new study showing where the right references should be, the implication will be that there will be many individuals that will be called that you are in the normal range. Previously, they were told that they had abnormal numbers, but it's within the normal variation for the general population. So the implications are huge for the individual. Instead of being told that you have a condition, you're told that you have a normal reference. If you had been told you had a condition, you probably would be followed once a year for the rest of your life. And having been in the field for many years in the United States, many of these patients probably would have undergone bone marrow biopsies, probably PET CTs and MRIs and other types of workups. So the fact that we can now sort of clarify what the correct reference should be, there are a lot of individuals that will not be told that there is any need for any further workup. That's a huge step forward for the field. To clean this up is a huge accomplishment. I want to lastly say that we actually made this observation in the lab about 10 years ago when we screened 5,000 people, but the field was not really ready to accept it. So we had to use the entire iStop-MM study to really generate a large sample size with over 80,000 cases. It takes a lot of time to clean things up in medicine, doesn't it?
Oh, absolutely, absolutely. I think you got it right. I really like the word iStop-MM. So let me ask Dr. Lang. So given the extensive data collection and analysis performed in the iStop-MM study, could you share some of the challenges you faced in gathering and interpreting this data?
The challenges in gathering this data is, of course, this is a huge accomplishment, and a lot of people that have participated in the gathering of this data. What was kind of smart in this gathering of data is that we were able to collect the blood samples when individuals went to take a blood test for something else. They had already accepted to participate in the study, and then when they went to the blood bank to donate blood, or when they had to take control blood test because of some other disorder, they also took an extra sample to screen for this. And when we have screened all these individuals, what's good in Iceland that we also have great linkage of comprehensive health data that we can connect to these results, and we can look at, we have very much information about these individuals, both their kidney function, which is very important in this paper, where we can estimate their kidney function very well for all these number of individuals, but also their previous diagnosis. You can even see their medications, very much data that we can look at in these individuals to answer many important questions in the future.
Thank you so much. So going back to Ola. So clearly, I completely agree with you. Changes in medicine are hard to implement. And there are no absolute reference ranges in any of medicine, but it takes a long time to implement any changes. So your research suggests that the standard reference intervals led to overdiagnosis. So how do you plan to address potential barriers such as clinician awareness and guideline updates in implementing these revised intervals in the real world?
When you do a study like this and you show that there is a lot of overcalling, I think one of the big challenges I think we internally, of course, have been facing and wondering about is whether we can really go out and tell everybody to follow these rules. So how do you prove that this is really right? Well, so we have followed people for a long time with these low levels that we are now calling normal. They are normal. And we have found that none of these patients have actually progressed. So we feel very confident in the validity of these results. So I think going forward, we will have to communicate the results from the study, but we will also have to articulate the long-term follow-up showing there is no evidence of that actually none of these patients have progressed. So I think providing that evidence will be important. And I think that the way to roll it out here in the United States will be to work with the big lab providers like LabCorp and Quest, and also to work with the specialist organizations for laboratory medicine and make sure that it's get implemented from the right sources for the people that are the stakeholders. So then it can trickle down to the chiefs for the different laboratories around the country in all the big laboratories at Mayo Clinic, at Sloan Kettering, MD Anderson, etc., etc. So I think working with the big commercial labs and also the professional organizations. And of course, we are very happy that this gets published in JAMA Oncology because JAMA Oncology is a fantastic place to publish this type of information. It has huge impact.
Thank you so much, and congratulations to amazing investigators across the sides of the Atlantic. So now we have two investigators from two different continents. Let's ask a question to Thorir from the European perspective and question to you, Ola, from the American perspective. So first to Dr. Thorir. How do you anticipate the new definition of LC-MGUS might affect the psychological and financial burdens on patients? And what measures can be taken to ensure that these changes are effectively communicated to the healthcare community? Let's talk to you about the European perspective.
Yes, I have to agree that it's very important that we get out with this information. It goes into the professional societies and guidelines as soon as possible, and of course be validated in external cohorts so we have better ground for this. But I think the impacts of this can be substantial for the patients and also for the healthcare system, because although the patients here in Sweden, they don't pay that much for healthcare, but for the utilization of healthcare resources and to decrease the anxiety and the time and stress that's related to having to be under follow for a pre-malignant condition is something that's very hard to assess, but I think it's substantial. And I think it's very important to try to prioritize our limited resources in the right way.
And now on to Ola for the American perspective on the same question.
I think I agree with, of course, it was Thorir's bringing up that the anxiety component is there, being in practice for many years. I've seen many patients coming with these findings and they get very, very worried about it. Very understandable. Some people more than others. There is an uncertainty, of course, if you have something. Although the risks are very low, this is no risk people think about. So you don't think about, say, driving a car or riding the subway or other things. There are risks, we know, in life with everything. But now there is a number that you follow and you do blood tests. People get very worked up about it. Yesterday I was in busy clinic. I saw a lady in her early 60s and her numbers had just changed a little bit. And she asked if we could do the labs much sooner than we had planned to repeat it in 1 year. So a lot of these things, I think, for us in practice, we see it every day when we go to clinic, how patients relate. There is less information from systematic studies, but as part of the iStop-MM, we have planned, and there is ongoing work trying to capture this in a more systematic way, which will be also another piece coming out in the future that we will publish. As for the cost, it's expensive to do blood tests. It's expensive to come and see doctors and nurses and do all these things. So obviously, the American system is a little bit different from the universal medical healthcare system in Europe in terms of who pays, but the cost comes down somewhere and someone has to pay. So there's a co-pay for patients and there are the insurance companies. I think as a general take, in my opinion, it's the same thing, that we shouldn't spend money on things that are not accurate to spend money on. So if you don't need to follow people, we should stop doing it. So I think that's the American perspective from my point of view.
Thank you so much. So looking ahead, what additional research or studies would you consider important to further validate and explored the implications of your findings in our different populations, different countries, and different settings. Let's ask Dr. Thorir first.
Yeah, I think it's very important that we look at these new reference intervals in all different clinical scenarios. Now we have redefined light chain MGUS, and it's actually already been looked at in other cohorts to see, and it looks good. Looks like it performs well in other more diverse cohorts. But it's also very important because the serum-free light chain measurement is used in many different clinical scenarios for risk stratification of both MGUS and myeloma, in detection of AL amyloidosis, MGRS, other monoclonal gammopathies of clinical significance, and even in treatment response assessment. So I think it's very important that we try to validate and look at these new reference intervals if they perform better than the original ones or not in these different scenarios, so it can be implemented on a wider scale.
Thank you so much. And Ola, as one of the world's experts in this disease, what would be your closing thoughts on this, and what would be the next steps?
I think that this study is a big step forward for the field. It takes a long time to generate the data. It's taken us 10 years to generate the study. We validated it with another internal cohort as well. We feel very confident in this. There will be additional studies, I'm sure, generating data from other populations around the world. We will continue to learn. It takes a lot of time to learn. I think in a broader context, the myeloma precursor field is just about to change. I think in 2025, the FDA is anticipated to vote at ODAC on the first registrational study for the treatment of smoldering myeloma, which is another precursor condition we have in myeloma. So we have multiple myeloma, and then we have two precursor conditions, the monoclonal gammopathy and smoldering myeloma. They are two clinical entities, and I'm not sure that they really are too distinct. Maybe it's just you're closer to myeloma or you're less close to myeloma, you're further away. But nevertheless, the smoldering myeloma condition is now being up for discussion by the FDA, whether this registrational study that uses Darzalex, the CD38-targeted antibody, shall be approved. And I think we all believe it will. The results were published a few months ago in the New England Journal of Medicine. And if this happens, which I'm sure it will, we will start treating patients with precursor disease. So it will be even more important to make sure that we treat the right patients that truly have a condition that is at risk of progression. The monoclonal gammopathy that this study focuses on is not the same as smoldering myeloma. So these patients should not be treated. But patients that have more disease, the smoldering myeloma, and in particular if they have a higher risk of progression, that's where the new development for treatment will go. So I think the field is moving to earlier therapy. So I think it puts even more focus on the preciseness of calling condition a condition and normal. So that's what this study is about that we talked about today.
I'm Dr. Vivek Subbiah, and I've been speaking with Drs. Ola Landgren and Thorir Einarsson about new definition of light chain monoclonal gammopathy of undetermined significance, revised serum-free light chain reference intervals. You can find a link to the article in this episode's description. To follow us and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.